Hello, everyone. My name's Paul Anthony, and as Michelle says, my background's in mental health. So I trained back in the 1980s. I don't know, I can't see you all, so I don't know. There might be some people from remember the 1980s. So I trained at St George's Hospital in the mid 80s. I was a student nurse there, and from there I went into teaching and started training. Nurses up at the university for many years. And then also for the last 25 years, I've worked as a cognitive behavioural therapist in clinical practice, mainly working with emergency services. So I work with the police currently, as well as in the past, and the fire service, two fire services actually, and also have a role within some manufacturing industries as well. And I'll come back to talk a bit more about that later on. In recent years, I've also started practicing EMDR, which many of you might have heard of. It's eye movement desensitization and reprocessing therapy. So I use that in working with trauma, PTSD and trauma, but it's also got a wider application now as well. So it's used in performance enhancement and coaching work as well, in helping people improve various aspects of their practice. And I just want to as well acknowledge, you'll see the site, we've got Staffordshire University, I'm a part-time lecturer there, but also Swift Psychology. So the research I'm going to be talking about later was conducted by Dr. Michael Swift of Swift Psychology, and also Alan Dovey, who's the director of Working Minds UK. So I need to acknowledge that this isn't all my own work. In fact, I wasn't really involved directly in the research. My role is more, I think of myself as the operations guy. I'm the one that deals with the organisations, deals with the employees and the clients, and working with people in distress. That's really predominantly my role. So what we're going to talk about then today is we're going to start off defining burnout, because it's got quite a long history, really. But it probably in 2019, it was perhaps more clearly defined when it was recognised as a workplace syndrome by the World Health Organization, and it's now in the new ICD-11 as a workplace syndrome. So we'll look at definitions. We'll look at some common signs of burnout. And then I'll come on to talk a little bit about the research that's been done in the manufacturing industries and in the emergency services, predominantly the fire service and paramedic services. We'll look at the clinical occupational psychology enhancement survey. It's a bit of a mouthful, so we often call it the COP-ES. And that's again Dovey and Swift, Working Minds and Swift Psychology. They've produced that tool and conducted the research with it. And then we'll finish off reviewing and discussing proactive approaches to identifying and addressing burnout. That's the kind of plan, if you like. There will be an opportunity for a little breakout session later on, where you can have a discussion and share some ideas, and then we'll have an opportunity for some questions and a Q&A if there's any questions you want to share. Okay, so in terms of the historical context, then the idea of burnout has been around for quite a long time. So probably Herbert Freudenberger in 1974 is often credited as one of the first people to recognize burnout. He was an American psychologist who was working in the area of substance misuse, but he also he conducted what they call free clinics in America at the time and therapeutic communities. And because he was working with substance misuse, the term burnout was often used at the time as a description for people who were really reaching that point of exhaustion because of the long-term substance misuse. And what he started to notice was that some of the symptoms that he saw with people with chronic substance abuse, he started to recognize in his colleagues, people he was working with, because of work stress and the demands of the workplace, some of the similar things, the exhaustion and the depersonalization, which we'll come on to talk about later. So Freudenberg is often sort of credited with one of the first people to talk about burnout in the work context. But I suspect, really, if you think about it, it's probably been around for hundreds of years, as long as people have been working. and I'm sure burnout symptoms have been there. So later on, then we've got Christina Maslach. Again, you can't talk about burnout without talking about Maslach. And what she did really was to Freudenberger more recognized it in a qualitative context. He described it. Maslach added another dimension to it with more systematic research, and she adopted a more quantitative approach to that research. And as a result, developed the Maslach burnout inventory, which is still used today. It's one of the tools that's used to measure and research burnout. And Maslach, back in the 70s, she described burnout as a prolonged response to chronic emotional and interpersonal stresses on the job. So that was perhaps an earlier definition, but we've moved on a bit in terms of definitions from then. And another key player from the past, if you like, who I've been revisiting in my reading recently, and I've realised it's still really, really relevant to today's context. Some of you might remember Hochschild, Arlie Hochschild. And again, I was introduced to her work in the 1980s when I was a student nurse, and it's the concept of emotional labour. So in there's a text, I've written it down here somewhere. The Management of Human Feelings was one of the books that Hochschild wrote in the 80s, and also there's lots of later texts. And really, she described emotional labour as the process by which individuals manage and regulate their emotions to meet the expectations of the job or the social role they're in. So she was a sociologist, and she studied, she studied what we'd now call cabin crew on airlines. That perhaps in the past they were called sort of air stewardesses or air stewards. And what she was interested in is that that kind of emotional sort of expression that you have to maintain in a professional role. So, for example, same in nursing or midwifery, there are times when you might be feeling really frustrated or angry at the way you're being treated, perhaps by a client or a patient, or you're feeling that anger, but we don't show it. And because we're maintaining that professional demeanor. And Hochschild described this as surface acting. It's when we're feeling the emotion inside, we're feeling angry because we're being unfairly dealt with, but we don't show it. We keep that professional front. And I'm guessing that most, if not all of you, have experienced that at some point. And she also distinguished that deep acting, and that's when you're sort of maintaining that professional demeanor. You're not showing the inner emotion, which might be anger or frustration, but you're also, if it's deep acting, you're also trying to really empathize with the patient or the client in front of you, and that's can be more taxing because you're trying to put yourself in their position and understand what they're feeling. So it's the and there was another phrase that she coined around that. She described emotional labor as the management of human feelings performed in exchange for pay and as the consequence of employment. So it's really managing your own emotions in that professional sort of role. So again, these are some key players. There are other people I haven't mentioned, but I think it's useful to acknowledge that this has been with us for a long time, and probably going back into history as well. So that brings us up a little bit more to recent times. And as I mentioned at the start there, the World Health Organization in 2019 recognized burnout as a distinct occupational syndrome. So it's a syndrome, not a medical condition. So if you go onto the ICD-11 portal, which is freely accessible on Google, you can put burnout in it and it will come up with the definition. And the idea is burnout is a syndrome conceptualized as resulting from chronic workplace stress that has not been successfully managed. And there's the three elements to this. There's feelings of energy depletion or exhaustion. So that's a key sort of presenting feature. Increased mental distance from one's job, or feelings of negativism or cynicism relating to one's job. And then as a result of that, reduced professional efficacy. So that's a kind of a much more recent, and it's interesting that that definition sort of came out just before the pandemic, and then you could argue that the pandemic really shone a spotlight, certainly for certain professional groups and certain people during the pandemic. They did start to experience significant burnout as a result of what was going on, really. So it came out just before the pandemic, that definition. So I just want to talk a little bit about burnout in relation to other sort of conditions and diagnoses, because it does get quite confusing in terms of how we define burnout. There's not always clear boundaries between burnout and other sort of diagnoses or conditions. And burnout is often perhaps misdiagnosed or diagnosed as depression, for example, or something like adjustment disorder, which can occur as in a result. It's like a sudden change, like a trauma event, or you're struggling to adjust to a significant change in your life. So burnout is often kind of can co-occur with other things, or it can be mistaken for other conditions or disorders. And there is a relationship between those. So this isn't exhaustive, but just to give you an idea then. So for example, burnout can increase vulnerability to the development of PTSD and trauma. So I work a lot with the police and emergency services. So and as you can imagine, I'm sure in your roles as well, I mean, there's a lot of stresses in the profession at the moment from midwifery that I'm aware of from recent events and in the news and things. It's there's a spotlight there, isn't there? It has been in recent years. So if you're experiencing the symptoms of burnout, and they often develop over a longer period of time, that diminishes perhaps your ability to cope, your ability to manage what's going on. So if you then encounter a trauma, so for example, I'm working with a police officer at the moment who was struggling with burnout for a long time because of a huge workload, but he then encountered a really serious incident where he was violently assaulted. Things went wrong. So his pre-existing burnout meant he was more vulnerable to developing PTSD. But of course, it's bi-directional. It can work the other way. So if somebody's had, which again, I work a lot with a lot of people who've had trauma incidents, and some are diagnosed with PTSD in the past, that can diminish their ability to manage and cope with emotional regulation, for example, which then subsequently can leave them vulnerable to burnout. There can also be a relationship with burnout and moral injury. So moral injury is really when something like this happened a lot in COVID. It was again came under the spotlight following COVID, the idea of moral injury. And moral injury is the distress that's caused, sometimes called moral distress, when you're acting in a way that breaches your own values and your own principles and values, your moral principles and values, and often this can be through no fault of your own. So through the pandemic, people were perhaps not able to complete their duties in the way that they wanted to. They were having to make decisions around patient care, for example, if we look at it in the healthcare context, that went against their own moral judgments. They felt distressed by this. It's moral distress. So if you're already and it can lead to people transgressing their own values, doing things that go against their moral code for whatever reason. Initially, it came from the idea of moral injury came from the military, and it was when soldiers perhaps found themselves having to act in ways that breached their own moral and ethical values. So if you're burnt out, or you're struggling with burnout, then your professional efficacy can be reduced, which is one of the cardinal sort of presenting features. So then you may well then be more vulnerable to making mistakes. So you might make errors and things go wrong, which then leave you with a sense of moral injury because you've transgressed your values. And of course, if you're in a situation like during the pandemic where there's sustained moral injury, that can then also leave you vulnerable to burnout. So there's a bi-directional relationship. And just to finish off with this, with some of you may have heard of post-traumatic embitterment disorder. This is it's a form of moral injury, really, but it's when you haven't transgressed your own values, but somebody else has. And typically that might be your employing organization. So this happens when people are under investigation, for example. So again, working with the police, I work with a lot of police officers who are under investigation. They themselves know that they've done nothing wrong, that they're sure of that, but for understandable reasons and for public trust and confidence, they might be under investigation. And that can go on for months or years in some cases with the people I'm working with. So imagine that you're under that level of threat of investigation from your organization, and it could go on for months and years. And then in most cases, they're cleared. There's no further action, but they're left with this sense of embitterment. Myself and my family have been put through this investigation for years. I've been found innocent. There was never anything to it in the first place. So they're left with a sense of what we call post-traumatic embitterment. If this is becoming increasingly part of my job, working with this, and again, it often goes hand in hand with burnout. And if you're interested in post-traumatic embitterment disorder, the person to read is Michael Linden, and there are particular types of forms of CBT, something called wisdom therapy, that's used in the treatment of that. So again, if people have been through a series like an ongoing investigation for months or years, it can leave them with this sense of embitterment disorder, which then can make them more vulnerable to burnout going forward. And again, burnout can leave them more vulnerable to developing post-traumatic embitterment disorder. So the boundaries are not always clearly defined between these different types of disorder or diagnoses. But what we try to do in the work that I do is we try to get a sense of what is going on for this person. What is the primary driver? Is it trauma? Is it burnout? Is it moral injury? Is the post-traumatic embitterment disorder? What are we dealing with? And I'll share with you a little framework that we use to do that later on in the presentation. Again, very briefly, just to talk about some other related concepts that relate to burnout. Now, I know that probably you all will have heard of compassion fatigue. And there's a relationship between, so you might ask, well, what's the difference between compassion fatigue and burnout? There's parallels and there's overlaps. And I guess I've jumped down to the bottom one here, but if we look at compassion fatigue there, a definition is a state of exhaustion and dysfunction, biologically, physiologically, and emotionally as a result of prolonged exposure to compassion stress. So it's that, and I'm sure many of us on the call here today will have experienced this. It's that compassion exhaustion. So there are lots of overlaps with burnout. But I guess the key things is that in some roles, like I work with manufacturing industries as well, where we work with burnout, and that people can still experience burnout because of work demands and work stress, but there may not necessarily be that interpersonal compassion element there, or it's not as prevalent, if that makes sense. So in other words, but compassion fatigue is often a part of burnout, but it doesn't necessarily have to be. You can develop burnout without that strong interpersonal element being there. And also there's an overlap with depression and burnout. And some people, there's still a lot of debate in the literature about this. Some people would argue that, burnout is depression, and people will argue that we're splitting hairs around this. But generally speaking, depression is viewed as more pervasive and caused by multiple factors, not just the workplace. So you can develop depression through biological processes. It can be part of people's personal lives and relationship breakdowns in their personal life. It can develop as a result of multiple things. Whereas burnout it's a workplace syndrome. We're identifying that way. Another key difference is that burnout, you can have a depression, a diagnosis of depression just by having the key cardinal symptoms for a 2-week period, whereas burnout typically is a much longer period of development. Freudenberger, interestingly, said that it develops over about 12 months. Whereas you can develop depression in the ICD-11 criteria, you can be diagnosed after 2 weeks with having the symptoms most of the day, every day for 2 weeks. And just to mention as well around burnouts, another controversial area with this is that burnout's been associated with like the sort of employment and the paid workplace, but a lot of people working in unpaid caring roles have challenged that, and they said, well, I might not be being paid here in the formal sense, so I'm not employed, but I'm working in an unpaid caring situation, perhaps caring for a relative in the context of dementia care at home, for example. And they argue that, what they're experiencing is very much like burnout, and it's perhaps a bit unfair that it's always just associated with a paid workplace. So there's a few debates going on around that, but hopefully that clarifies it a little bit. So in terms of defining the concept then, burnout is distinct from other related concepts for the reason we've just talked about. However, there are not always sharp or clear boundaries, and it can overlap, it can co-occur. And the conclusion then, and comes a lot from Alan Dovey and Mike Swift's work, really, rather than viewing the concept of burnout as a set of symptoms, it should be looked at as more of a process or a journey. That's one of its defining features. You don't develop burnout overnight. It tends to develop over time, and it can be connected and related to things like trauma, depression, compassion fatigue. They can all be in there, but we need to get an individualized understanding of that person's journey to burnout, really. And that's what sort of work we're doing in occupational health at the moment. Very, very briefly, some common signs of burnout. And again, these are things that, certainly I've experienced at times in my career, and I'm sure many of us have. We look at the changes are in the four domains, often, of emotion, mood and emotions, thinking and thought processes. So that includes things like reduced concentration, impaired memory, but also the content of the thinking itself. So things like I'm not good enough, I'm letting people down, negative thoughts, really, negative thinking. So we've got the emotional change there as well: anger, frustration, irritability, the whole range really of emotions can emerge depending at what stage and at what point you are in the journey towards burnout, really. And then, of course, there's the physical and biological changes, fatigue being a key one, but insomnia is often there, and somatic symptoms, which can often be medically unexplained. Headaches, skin problems, stomach problems. This is not an exhaustive list. It can manifest widely, really, in very physical ways. And then the social changes there: feeling alienated, a sense of isolation, and conflict within relationships, whether that's at work, and of course can come into the home life as well. And then behavioural changes. So loss of sense of humour is an example of that. Lack of empathy, and again, things like compassion fatigue come into that. And of course, people might start to use maladaptive coping strategies, things like excessive use of alcohol or drug use, and poor self-care. So we'll look a little bit later at a model of burnout, which extends this a little bit. So I was planning to do a little breakout room there, but I think it's probably better that we leave this later on. So we'll leave this for the end of the presentation. So coming back to this idea of burnout then, in terms of sorry, that's Dr. Swift just ringing me now. It's just, sorry, it'll go in a bit. So it's useful to think of burnout in terms of this journey, as we were talking about. And many of you may have come across this before. It's the Yerkes-Dodson performance and stress curve. So often people might go on a journey to burnout, and we might achieve a position of optimal performance initially. And the thing in employment is that that's where, as an employer, we often want our employees to be. We want them to stay at optimal performance as managers and business leaders. We want your employees to be at optimal performance and just keep going, just keep sort of staying at and operating at high productivity and sort of high level of functioning. But of course, as we all know, you can't maintain that optimal performance indefinitely. It's if you're at that peak performance and it's ongoing and the demands and the stresses are not changing, we're all human beings. It cannot be maintained, and often there comes a tipping point. And a useful parallel to draw with this, it comes from sports psychology and the world of sports, and it's called the concept of periodization. So if you think of an elite athlete, for example, let's say somebody who's I don't know, 100 meters runner for the British team, and they're training for the Olympics. So what they will do is they will train systematically, and the aim is to reach peak performance just before they run in the Olympic Games, so that they're at peak performance. But after that point, with periodization, there's a period of recovery and sort of winding down from that, because they acknowledge it in sports that if you don't do that, you're risking you're risking injury, you're risking damaging their future career, because they can't maintain that peak performance indefinitely. Because of course, athletes are not doing an Olympic Games race every week. They do the one race or the few races, and then they have a wind down. They don't keep doing that an Olympic race every week going forwards. So this idea of periodization then is something that's been adopted a little bit in occupational health. And the idea is that to start to look at those people who are operating at peak performance, and rather than just saying, oh, they're great, they're fine, they're operating really well, let's just leave them. We don't need to worry about them. They're doing great. What we're sort of now thinking is, well, maybe we need to start checking in with these people, because they're at peak performance. Can they maintain that, or are they on a journey to burnout? And if you think about it, when you have people operating at peak performance like that, and I've done this myself when I was in management roles in the past, I've often looked to them as, oh, I'll give them some more work because they're really good at, and I know they'll do the work. So you end up actually giving people in that position more work, and they keep taking it and they keep dealing with it. So the idea is to have a more proactive shift in how we look at performance, and start to look at when people are at that peak performance, maybe that's the point where we need to be checking in with people. You need good management practices to start checking out, are they having the elite athletes have the recovery period. Are they having the recovery period? Or how are they managing their stress? Are they on the road to burnout? So it's a proactive shift really in looking at people in light of this curve, for example, to see, are we putting them at risk in a situation where they're going to keep going? They're doing a great job, so we give them more work, and it's not sustainable, really. Now, it has to be handled very delicately, and in the organisations I'm in, because you don't just want to go to people for them to think they're doing something wrong, so it's a delicate discussion to have, and it requires effective management to talk to that person and say, you're doing a great job, but is there anything that we need more to do to help you sustain that and help support you in that? So it's the idea of periodization from sports psychology, because what we don't want to happen is this, that what started out as important, meaningful, and challenging work starts over time to become unpleasant, unfulfilling, and meaningless. So energy turns into exhaustion, involvement into cynicism, and efficacy turns into ineffectiveness. And that's just something I've adapted from Dovey and Swift's work on this. So I'm aware that I'm doing a lot of talking here, but I'm sticking to time. But we will have an opportunity for discussion and questions afterwards. So, in terms of the stages of burnout, as I mentioned earlier, Freudenberger recognized in his colleagues that it seemed to develop over up to a 12-month period. It was a journey. It didn't happen overnight. And there are various versions of the 12 stages of burnout that you might see or you might have heard of. I won't go through all of this in great depth, but this gives you some idea of what we mean by that journey. So you might start off um, being sort of highly invested. Some people start with a sense of imposter syndrome or not being good enough, which is why they might overcompensate in the workplace and work even harder. And so it might start at this point, but then as we get to the red zones, the amber and red zones, these are the kind of changes you might see. I won't go through all of these, but often as things start to be more challenging, there might be denial of problems emerging. People start to withdraw from relationships, odd behavioural changes. That means things like sudden outbursts of anger, for example. Depersonalization is a key feature that often comes up with uh, discussions around burnout. And that's when depersonalization is when you almost start to feel a bit detached from people around you, but also detached from yourself. So you get this with depression as well. So sometimes people feel as though they're almost looking at themselves from the outside in. They feel that they don't, things are starting to feel a little bit unreal. And then, of course, it can progress up to full burnout syndrome, which can be almost mental, psychological, and physical sort of collapse there. So I won't go into that in too much detail for the sake of time. But this is an established, and again, Freudenberger talked about 12 stages back in the 70s, really. Um, so just to summarize then, burnout isn't a medical condition, it's a workplace syndrome, but there's lots of overlaps, as I say, with depression, trauma, post-traumatic embitterment disorder, moral injury, that they're all elements, compassion fatigue, that it can overlap with. The current thinking is, and a lot of the work that we're doing with the fire service, the police and paramedic services and manufacturing industry is a need to focus on the journey as well as the outcome. So we're looking at how did the person get to this point? Where are they in the 12 stages, for example? Um, and the idea is if we can assess the process, then we can plan interventions. And by interventions, that's what the organisation do and what the environment that the person's in can do, but also the individual themselves. And we've mentioned the concept of periodization from sport. So that if you have the presentation, you can click on that link and it'll tell you more about that. And also, the current thinking is it is important to identify burnout as a distinct from but related to other conditions. And that's because if we can clearly identify what's going on, we've got evidence-based treatments, for want of a better word, but evidence-based interventions for them. So for things like if the driver is post-traumatic stress disorder, and burnout has made the person vulnerable to that, then we would use things like trauma-focused CBT. If it's early stages of burnout, then we might look at coaching and effective management practices and reasonable adjustments in the workplace. What it is a proportionate response to where the person is using the correct interventions that we know are effective from research and evidence. So we'll come on to that a little bit more later. So in the spirit of this proactive approach that I'm talking about, where we're not waiting, typically in mental health, when I first started, it tended to be that we had a reactive approach. We'd wait for people to become unwell and then we'd, intervene. But as we all know, sort of prevention is often better than cure. We want to try and pick up issues and difficulties early. So what Swift and Dovey have done recently, and this is all very recent work, is develop a tool for evaluating occupational well-being and distress. So it's a bit of a long-winded name. I say it's the Clinical Occupational Psychology Enhancement Survey, or the COPY-S as it's referred to. This is you can get this. It's in the Occupational Health Journal. There's the reference there. And just why I'm mentioning this, the At Work Partnership, who produced the Occupational Health at Work Journal, are developing a burnout course. It's going to be, my understanding is it's going to be a full day of training in burnout. And a lot of the things I've mentioned and will be mentioning for the rest of this presentation will be sort of explored in much greater depth on that course. So that'll be coming out soon from the At Work Partnership, and that will be in conjunction with Working Minds and other organisations. So what is it then? So the COPS tool is basically, it's a 15-item tool designed to assess psychological well-being, distress in occupational settings. The key difference with it is it doesn't just measure psychological distress, but it also measures people's so what are their healthy behaviours, if you like, or their behaviours that we know are associated with well-being. And so it draws on sort of a number of evidence-based psychological frameworks. So one of them being the PERMA model, which comes from positive psychology sort of field. And again, without going into this in too much depth, the PERMA model looks at positive emotion, the degree. So is the person experiencing positive emotion? Are they engaged in sort of work and their personal life, the quality of relationships? Does their work provide meaning, and do they have a sense of accomplishment? And then there's lifestyle factors from the SEEDS model. So, and again, you all know about this, it's adequate sleep, exercise, education, diet, social connection, etc. So the tool doesn't just measure sort of symptoms of anxiety and depression or distress, but it's also looking at how well is the person engaging with healthy behaviours and activities that we know lead to well-being. So it's assessing well-being as well as distress, in other words. So how it works is employees are sent a secure link to complete the survey online. There's lots of ethical issues around this and around screening in general. So it's all done with consent. People don't have to do it. There's a lot of information given around the purpose of it and why it's used. And again, with any kind of screening, part of the ethics of it is that you need to have services in place or help in place if problems are picked up. So the COPS has behind it a sort of a pathway of support, a proportionate pathway of support, depending on how the person is scoring on the tool. So again, there's a simple, to make it practicable, there's a simple kind of traffic light system for picking up people who might be in the early stages of burnout or distress. Now, it's not quite true what it says there about no action required if they're green. So that might be something that we look at. It might be somebody who, they're doing all the right things to keep themselves healthy. Maybe they're sleeping well, and there's no signs of distress, but of course they might be at the top of the curve that we talked about, they're at peak performance. So it doesn't mean that there's not necessarily no action. It might be that that person's functioning well at the moment, but as we say, sustained effort like that, we still need to look at people's well-being when they're still operating at peak performance. But it certainly will pick up people where there's an urgent referral needed, or there's the early signs of difficulty on the burnout journey, for example. So the idea is it helps organisations spot early signs of distress and take proactive action to support mental health. So we're trying to intervene before people become unwell and burnt out, because once you do hit burnout, it takes time to recover. It could be 3 to 6 months potentially to be working up to that point where you're back reintegrating back into your role, maybe. A lot of people that I work with in emergency services sadly resign as a result of burnout. So we've got sickness absence problems, losing people from services. So we're trying to avoid that, and trying to get in there early to prevent these kind of difficulties. There are a lot of other ethical issues that I don't have time to go into now around this, but it was all just to reassure people that it went through the appropriate ethics committees, and there was lots of involvement with union and staff. It was all done with staff consent and fully informed consent. So the results then, the initial research that was based on data from 416 participants, and these were people from emergency services and manufacturing services. I won't go into all the statistical analysis of it, but it was compared with another well-known tool, the Core 10. It's used a lot in NHS psychological therapy services. So it was compared with that. So we know that it's got convergent reliability. It's picking up distress in the same way that well-known validated tools are. It clearly separates people with high distress from the low distress, or certainly the findings of this study suggested that. So it is effective in picking up that sort of discrepancy between high and low distress. And also it seems to be good at predicting mental health outcomes from the initial research. Again, there's more research planned and more longitudinal studies, but consistently gives stable results and is useful in the real world workplace settings. It's really designed for an occupational health setting, whereas things like the Core 10, are used very widely in lots of settings. It's used in the IAP services and NHS talking therapies, for example. It's a broader measure, whereas this tool is designed specifically for occupational settings, really. So that's the COP ES that's used as part of an overarching strategy to be proactive about picking up difficulties early, and hopefully identifying people early in that burnout journey. And then we've got a sort of a suite of proportionate interventions that we can offer people depending on where they're at in that journey. And again, I'm very conscious of time. I need to finish on time. So just to give you an insight into this, about what interventions go hand in hand with this kind of psychological screening and what we're doing at the moment. So the main thing is you've got organizational buy-in to this. So people are recognizing burnout as a problem. They recognize it's in everybody's interests to address this problem. It's in the interest, very importantly, of the person themselves, the individual, because it has such a huge impact on their health and well-being. And it can lead to long periods of sickness absence and even people leaving. So there's a proactive approach and a lot of awareness raising and like cultural shift. And again, it's that cultural shift about saying, we need to look at people who are performing really well and seem to be at the top of the Yerkes-Dodson curve. Are they able to maintain that? Are they okay? Do we need to check in with that? We don't want to just keep giving them more and more work because they're doing really well. So there's a bit of a shift with that around from usually where we would, and rightly so, focus on the people who are struggling in distress, but let's not ignore the other dimension to this. A lot of education going on within organizations around stress management and management of burnout and other psychological issues. Then you've got the things like the COP ES, psychological assessment, checking in with people in line with all the ethical considerations. And as I say, you've got that organizational engagement and buy-in. So I know this is working particularly well with the fire services. I work with 2 fire services. It's working well there with those. And then the other part of the intervention is that we need to consider both organizational environment factors and factors to do with the individual. Now, this is really important because I work as a cognitive behavioral therapist, and earlier in my career, it used to be seen really that managing burnout and developing resilience it's all the responsibility of the individual. You know, it's your responsibility to manage your well-being, um, and cognitive behavioral therapy in some ways kind of encourage that a little bit. You know, I mean, I'm an advocate for CBT, but because it does say one of the key premise and principles is um, it's not the environment, it's your interpretation of the environment and the meaning of it to you that causes your emotional, behavioral, and physiological response. And that is still true. But of course, if you take the example of emergency services, you know, with the police and the fire, for example, we're putting the nature of the job is we're putting people into distressing situations. You know, a firefighter's running into the fire where everyone else is running away. Police officers are going into challenging environments. In healthcare generally, in midwifery, you know, we know that we're putting people into environments that are stressful. So we have a duty of care to people. So it has to be that there's the organizational duty of care to employees, and we have to look at the environmental factors, but then we look at the individual as well and the interaction between the two. And there's an approach that we use to facilitate this called a formulation approach. And hopefully, if we've got time, I'll share a little example of that with you. So that's the first part of it. Then it doesn't happen. There's a lot of preparation and organizational preparation, if you like. But then we've got early stage intervention. So if we're picking up, so this is where people are perhaps in the amber stage of that rating scale for the COP-ES. We might be looking at it's often it's a proportionate response. We don't want to be referring people straight to, you know, people like me, you know, CBT therapists and EMDR, and we don't want to, you know, jump straight into that and kind of pathologize, you know, natural human responses with it. So it has to be a proportionate response. So it might be self-help. It could often, and very importantly, it's effective management and effective management conversations with line managers. It might be coaching is appropriate at that point. So coaching is more about sort of personal growth and development rather than dealing with an actual mental health illness or issue at that point. And things like adjustment of environmental demands. So kind of things that already happen, hopefully, to a degree. If things are progressing further on that journey and people are starting to flag up more amber and red, then we're looking at things like cognitive behavioral therapy. And this is where I come in. I'm the operations guy, really. So I'm involved in actually working with people who are developing in the early stages of developing distress of whatever form that might take. So it might be things like CBT. Sometimes we use performance EMDR aimed at performance enhancement as well. So not necessarily just for trauma or things like anxiety and depression. And then we've got an effective pathway to support. So typically with the services that we're sort of trying to pioneer and develop, we'll have specialist services integrated within occupational health. So I'll go into occupational health departments. I'm over in Lincoln with the police. I'm over in Birmingham and other areas, going into organisations. So it's integrated within a sort of a pathway of support that's proportionate. And then, of course, we sort of move towards when people are, if they've been very unwell and off sick, then we're looking at relapse prevention and reintegration into work. So you've got the cultural awareness raising and education, and then you've got your proportionate intervention depending on where the person is in their journey and the problems they're having. So just to finish off, then I mentioned we use a formulation approach. This is a pseudonym, Carol. It's somebody I worked with. She actually comes from a different industry. She's not an emergency worker, but it's a little framework that we use to try and get an understanding of the individual in relation to the organisation and environment. So it's called a 5 areas formulation. You might have seen this. It comes from CBT. So you've got the environmental factors, it was the COVID pandemic, short-staffed and working in isolation, and large increase in workload for Carol here. And then it's the impact on, so that's the environment. And then she's interacting with the environment in terms of her thoughts here, her cognition. I must keep going. I can't let anyone down. A mood, increasingly anxious, and then the physiological aspects of this, headaches, disturbed sleep, and then the behaviors here. And you can see where some of the behaviors might be starting, the thoughts, the beliefs here, and the behaviors starting to push somebody into burnout when you think of the 12 stages. And then there's more to this formulation, because we might think, well, not everybody thinks the same way as Carol here in terms of their thoughts in relation to the environment. So how we determine that is by looking at the past and a more comprehensive formulation. So why is it that Carol responded as she did down here? Well, it's because she grew up in a family with a strong work ethic. Parents had high expectations, often critical. She had core beliefs around not being good enough and other people are better. And then we call these rules for living. It's like your values, really. So if I'm not good enough, then I must work twice as hard. So she had rules and values that are driving her. And I must always comply with requests from people in authority, otherwise I'll be found lacking. So for Carol, her own values and rules were driving her to work hard. And of course, she won't say no. So she wasn't saying no to work, and then she was trying to work twice as hard. And you can see that that's a pattern that could lead to serious problems, which indeed it did. And she became quite unwell at that point. So we start off with the 5 areas, and this is something you can use. You could use yourself to assess where you're at with this. And a more comprehensive formulation looks at the person's past and how that's influencing how they're interacting with the current environment. This is a little bit more advanced. This is when we're getting into more the CBT work and the kind of work I might do with people. That's a little tool there that you could use. It's used within coaching as well, and used within getting an understanding of what's going on in the person's situation, how they're thinking about it, their physiological response, their emotional and their behavioral response. And it can give you a little framework to start to look at what's going on with the person, what's happening in their environment, how are they responding to that, and it can help to give some clues as to what might need to change. These hopefully you'll have these slides here, but this is just a little bit more information on the SEEDS and PERMA model. These are things that are crucial for really preventing burnout and avoiding burnout. They're both evidence-based frameworks, and these are the ones that they're integrated into the COPY-S survey tool that's used in the organization. So if to maintain your health and well-being, we need to have an element of socializing, exercise and activity, education, and continuous sort of using your brain, if you like, diet and sleep, and then the PERMA model as well. So these are 2 very evidence-based models that are used a lot in well-being research. There is a workplace version of this. It's called the PERMA +4. And again, the references for all of this are in the list there. So you'll be able to look into it a bit more if you want to. And again, it's the PERMA model plus, and it's specifically for the occupational health context. So it's looking at, in addition, you need, not surprisingly, you need physical health. They talk about a growth mindset and sort of an optimistic aspect. Environment, and that means physical environment as well as importance for maintaining health and well-being in the workplace. So that's things like, natural light, for example, but also things like psychological safety and the nature of the culture that you're in. And of course, not surprisingly, economic security. People's health and well-being is going to be undermined if they're in a situation of job insecurity. So there's a whole paper on that, Donaldson et al. 2022 there, that you might be interested in looking into and seeing how your organization and team and context of work fits in with all these sort of ideas. And I think I'm just about on time. That's the reference list there. There's lots of links and that go into a much more depth on what I've been talking about.